My name is Jacqui Saw. I'm a consultant neurologist who is responsible for the Adult Epilepsy Clinic in the East Metropolitan Health Service in Perth, Western Australia. And it's my pleasure today to interview Professor Delanty, who is a distinguished consultant neurologist from Beaumont Hospital with a background particularly looking at genetic associations with epilepsy. We also have Ms. Kris Pierce here today for GETA, which is a patient-led advocacy group looking at rare and genetic causes for epilepsy, who has a personal experience of having a family member with epilepsy associated with SCN2A. So welcome to you both today. How are you finding it?
Great. It's a fantastic opportunity to visit, and really appreciate the kindness and the welcome that I've had, the opportunity to meet fantastic colleagues, some of whom I know and some of whom I just met for the first time.
Today's conversation is going to focus on patient-focused issues, looking at carers, family members, and what's happening, particularly in the paediatric transitioning to adult services sector, which, as we all know, is a very difficult arena. We would like to talk about that sort of critical transition of care and get your perspective as an international epilepsy member, highlight the challenges that you've experienced in your clinical setting.
Yeah, it remains a challenging area when children with epilepsy transition into adult care. It varies in terms of what age that might happen. I think there's no right and wrong answer. It is resource intensive. There's actually very little research or publications on this area. There are a number of colleagues internationally who are interested in this, including Danielle Andrade in Toronto and Riemann Abbott in Paris. But there's actually very little in the literature of how to do this properly. We know what's required. I think we do need to divide in some way. Like everything in life and like everything in epileptology, there's no one size fits all. There is a difference, for example, in the transition process, let's say with a teenager with idiopathic generalized epilepsy, such as juvenile myoclonic epilepsy, who has really no other comorbidities except dealing with their epilepsy in adolescence, and any chronic illness in adolescence is a challenge for that person, versus a child with a long history of a developmental and epileptic encephalopathy who has special needs, intellectual disability, behavioural problems, other comorbidities, and who needs to be cared for by family and other carers. So there's no one size fits all. Clearly, there needs to be a discussion from the paediatric side early on, well before the actual transition takes place, so that the family understands, is aware, clearly at some level they are aware, but it needs to be explicitly discussed in the paediatric world or in the paediatric neurology clinic that, look, in 2 years' time, we're going to ask adult neurology colleagues to take over your care because you're going to be 17 or 18 or whatever age. Obviously, the age can vary. And as I said, it depends on the actual circumstances, it depends on the epilepsy syndrome, it depends on the comorbidities. If we focus on the more challenging group of individuals with developmental and epileptic encephalopathy, then ideally, when the transition does take place, you have everybody in the same room on the same day. That's a counsel of perfection. To be honest, that rarely happens. I mean, fantastic situation where you had, on the day of transitioning to adult services, you had the pediatric epileptologist or neurologist in the room, you had the pediatric nurse specialist, you had a pediatric social worker in people with complex needs, and you had the adult epileptologist, the adult nurse specialist, and other support staff in the room. But to be honest, I don't think that happens very much. I mean, it may happen in some centres such as Toronto where they have a particular interest in it. So it is a challenge. Of course, with telemedicine, maybe you can ease some of that. You can perhaps get people in the room virtually. But again, even getting 6 or 7 professionals diaried to match over a course of a number of hours, even seeing a number of patients during their transition, it is a challenge. That's one issue, getting all the healthcare professionals in the room together, whether it's virtual or practical. The other challenge, of course, is getting all the information, the relevant information from pediatric services into adult services. And remember, if we look at children and adolescents who've got a history of developmental and epileptic encephalopathy, they have medical records going back 16, 17, 18 years. Sometimes that information is vital for the adult team to take over. And the other thing, of course, is that the transitioning process is an ideal time to review the diagnosis. I think that's not a criticism by any manner of means of pediatric neurology, but If somebody has a complex epilepsy phenotype, complex psychosocial situation from a DE, for example, it is a great opportunity to review the diagnosis. It's a great opportunity to review the previous and current treatment with anti-seizure medications and other medications. So information is key, and sometimes information is missing, and that's a problem. The other critical thing that's really relevant at the transition process, and it ties in, of course, with reviewing the diagnosis and reviewing the etiology or the specific diagnosis, is to ask the question, does new testing need to be done? And particularly we're talking, of course, about does new genetic testing or updated genetic testing need to be done, particularly in those individuals who don't have a specific monogenic answer for, let's say, the group of individuals with the DEEs. We know what we should be doing, but in the real world where we all struggle with resource issues, it's difficult. So that's kind of my take on the situation. That I'm not telling you anything, Jacqui and Kris, that you don't already know, I think.
No, that's an excellent summary. I wondered if we could just drill down a little bit on some of those points that you raised. All of us in the adult epilepsy arena need to be aware of. Transition is a big issue for us. And Kris, correct me if I'm wrong, but I feel like we are lacking in certain areas in the Australian adult epilepsy arena. And it's something that we absolutely need to address, particularly over the next 5 to 10 years. So it's interesting that you brought up the review of the diagnosis and review of the genetic testing. Are there specific things focusing on patients that you'd like the adult epileptologist to focus on?
The other thing I didn't mention, but it ties into what you just asked me, is education of adult epileptologists and adult neurologists. Every family and child, adolescents maybe has the opportunity to go to a complex epilepsy centre, but I think that's the ideal scenario. They should be going to a complex epilepsy centre, but adult epileptologists and neurologists may not be as au fait with the childhood DEs as they are with obviously the group spectrum of epilepsy disorders they deal with adults. So education is one issue. Education around genetics and the genetic etiology of the DEs is really important. If the individual hasn't had genetic testing for 10 years and we still have an answer, then the adult neurologist needs to be comfortable ordering a genetic test, whether that's a gene panel or a whole exome, and understand that it may provide very valuable information for the family and the individual and may actually guide new treatments. I feel strongly that the epilepsy community needs to be working together, where each complex epilepsy centre has a register of all the patients that they're treating with this monogenic epilepsy, because all of us, even in complex epilepsy centres, will only have 1 or 2 or 3 or maybe 4 patients, maybe a bit more with the more common genetic epilepsy such as SCN1A, but only a handful of patients related to each monogenic type of epilepsy. And if we want to understand the natural history of these disorders, which I come back to, then we need to work together. And then crucially, if there are new treatments, either with small molecules or gene therapy, is becoming a reality potentially for the rare monogenic epilepsies now, particularly with the SCN1A trial, the regulatory trial that's, I think, starting around now. So we need to have these patients identified for future therapies. The other thing, of course, is to go back to the natural history. As we know, many of these children are growing into adolescents and older adults, whereas maybe some years ago, because we had less therapies, less drugs, less overall quality of care, many of these children wouldn't survive into adulthood. So we don't understand the natural history of what happens when these children become adults. We need natural history studies as well. And the adult epileptologists clearly need to take this on.
Kris, would you like to add anything?
Thanks, Jacqui. So just for context, I have a 23-year-old son, Will, who has SCN2A. He was diagnosed at 14, and so at 23 has transitioned out of paediatric care. We went into a transition at the paediatric centre we were at, but what that consisted of was a letter to the GP. When we got to the GP said, "You're going to have to tell me what to do." That was our transition out of tertiary care. We are fortunate enough to have a adult physician, epilepsy physician, who's caring for him, who's very well versed in this area. But we live interstate, and we recently moved to a regional area and have tried to get him on the books in the hospital just in case anything happens. And nobody wants to take him up. So we haven't even been able to get him registered. And the reason we tried to do that is because we were actually overseas and he ended up in emergency. And we had the emergency doctors ringing out going, what is SDN2A? What does he normally look like? 'Cause at the minute he's presenting this way. And we were on a train between Madrid and Barcelona, I think. People need to have eyes across his history, trying to get that here. One, by transferring his old paediatric information, which we don't have access to. So we're going for a bit of a void. That's been our experience and that of others that we have spoken to. So it's definitely an area we can improve on.
So again, I don't know the exact circumstances, but the same thing occasionally happens in Ireland. I'm sure it happens in other areas of the world. It's suboptimal, to say the least, that a general practitioner is expected to refer a child with complex needs to the adult specialist services. I mean, it should be a direct referral from paediatric neurology to adult neurology. And of course, the general practitioner needs to be in the equation, needs to be copied, needs to know what's going on, because the general practitioner has a really important role in terms of chronic health management and management of other comorbidities. But a referral from a GP into adult neurology is not appropriate in this day and age, I think.
I'd have to second that. And I'm so sorry, Kris. Obviously we're commenting externally, but ideally I'm completely on board with Prof's plan. It'd be great if we could all physically be in the same room. But in the back of our minds, we always have to be thinking about the best way to transition a patient, because it's very confronting psychologically, even physically, for them to go from their lovely pediatric hospital to suddenly enter the adult sphere where things are very different. And the patients that you're sitting with are often very different too, to what you're used to. Just speaking from personal experience in WA, we've been really fortunate. Our pediatric colleagues, some of whom you'll meet tonight, have worked really hard in having a transition pro forma. It's just an electronic document which summarizes the medical record. And we found that quite useful. But again, the optional thing would be for all of us to be in the same room, same page, and smooth that process over.
Again, as we said, having all the relevant information is fantastic. And that would include, ideally copies of previous imaging and EEG studies as well.
Absolutely. So just talking to the two of you, from a practical perspective, are there things that we should be doing to advocate? So from a healthcare professional perspective, are there things that I should be doing to advocate? And Kris, I guess you could maybe comment on some of family initiatives. I mean, GETA is a great initiative. Is that a way for us to give a more comprehensive service?
I'll jump in. So I guess for me, like you mentioned, Jacqui, that when you're in paediatrics, you kind of have this wraparound care. And as a family, you feel quite supported, really quite in a holistic way, because they've got all those caregivers within the one hospital. That's not necessarily going to be the same in adult care. So I think for me, like when we are thinking about transition, it's not just the medical, because, when your child hits adulthood, you're starting to age yourself. And so we're thinking about who's going to care for our child and what does that look like and what care can we put in place and what systems can we put in place for this now adult cycle out of that sort of pediatric support. And it's not easy. It's a lot for parents. We're navigating a whole range of services and different, we call them portfolios. So like we're dealing with not so much education once they hit adulthood, but, disability, social supports, this whole range of things that we have to consider. So I guess I'll encourage emphasis on that holistic family-centred care as well.
I agree. More broader social holistic care is important. It's something that we see all the time, and that, of course, as the child is getting older, the parents are getting older. The parents always will have concern about what's going to happen to an adult child in years to come. That's a common and very understandable concern. The other thing we didn't mention, Jacqui, and again, I suppose transitions also adolescents with different epilepsies like juvenile myoclonic epilepsy or people who do not have comorbid cognitive difficulties. That has to be handled as well very sensitively and differently. The term wraparound care in paediatrics, going to an adolescent trying to become independent and having to deal with, at what stage, for example, does an older adolescent with GME tell his parents stay outside? All this kind of stuff has to be worked on as well. And there's no one size fits all.
Absolutely. And I think the first step is just being aware of the issue and then navigating it depending on the patient in front of you, right?
Absolutely.
But yes, it can be very tricky, sort of asking the parents to, I'd like to have a chat to this patient by themselves now.
Yeah.
Yeah.
My son in a disability planning meeting very adamantly said he wants to live by himself. This is someone that pretty much needs 24-hour support. So I'm sort of saying, that's great, very ambitious, and trying not to insert myself also in the back of my mind going, what does that look like? I just also wanted to pick up on one other thing, if I can. Earlier, professors talked about needing to educate adult neurologists and anyone else that's supporting these families. For us, and what I've observed across other families with transitioning children, is that often their symptoms actually change, the way they present actually change. So that sort of idea of it just being like quite catastrophic seizures. So like, for example, my son has controlled seizures, but the problems that we're facing are behavioural and intellectual disabilities.
Yeah. And I think, Kris, it's so important that you say what you just said, because that's been my personal experience, that the issues that a paediatric neurologist are dealing with are very different to what I'm dealing with when the person is 23, 25, 30 years old. And behavioural issues really come to a fore. And I'd be really interested to hear Professor's take on this. Has he had to engage more with psychiatry? What are some of the issues that he's experienced in these transition patients?
Well, yes, of course, you do need backup from psychiatry and neuropsychology for some individuals. There's no one size fits all, but you do need the support of colleagues, disciplines. If they're down the corridor, hopefully you can go and talk to them or get the patient seen. Behavioural management from an expert psychologist who has expertise in treating individuals with intellectual disability, or input from a psychiatrist in terms of using medications. In an ideal world, it needs to be a multidisciplinary care situation. I think one of the things that we could do, just talking about it here, every complex epilepsy centre is a multidisciplinary team meeting, an epilepsy surgery review meeting, looking at whether somebody is suitable for epilepsy surgery. We also now have a monthly MDT genomics meeting or epilepsy genetics meeting, but maybe we should start talking about an MDT meeting for individuals with very complex mental epileptic encephalopathies, even outside issues around surgery, because of course most of these individuals won't be suitable for resective surgeries. There may be more scope for specific MDT meetings around these individual care needs. I don't know if many centres, we don't do it specifically outside the two other MDT meetings.
Yeah, I think that that's a really great idea, because Kris, I think earlier you were sort of saying that this has really become a large part of his management issues. Is that correct, for Will's management issues?
Yeah. I think it was probably during COVID, it was the extra curveball we didn't quite need. After that, Will became quite focused on not being told what to do, because for a few years we were told when we could go outside our house and all that. So he's very, I'm in control, I'm the boss of me, which sounds very empowering, but it is quite impactful in terms of his day-to-day functioning. It's actually quite debilitating for him. So we engaged a psychiatrist. He also has been seeing a behavioural support person for many years just to work through some of the challenges. But now he uses that support to work through his worries and troubleshooting some of the problems that he encounters on a day-to-day. So it's become a much larger focus for us, with other things like his seizures being more stable.
The other thing that is a little bit of an unknown in some of the genetic epilepsies is how people with specific rare genetic epilepsies change as they get older. We don't know that. And clearly, patients need to be seen on a regular basis. They need to have some sort of access to the service, including ideally epilepsy nurse specialists, which we are very fortunate enough to. At Beaumont Hospital in Dublin, we have great advanced nurse practitioners in epilepsy, and they're a great resource for any complex epilepsy centre. And also, of course, in terms of the general medical healthcare needs, they really ideally should be seeing a GP with an interest at least once a year, even from chronic health management, even when they're well. And even things like dental care, for example, because that's another issue. Many individuals with DEEs can't tell us they've got pain, they can't tell us they've got a toothache. So the kind of chronic, regular healthcare needs, dental care needs are also very important. And we shouldn't leave it come to crisis management, I suppose.
Yeah, absolutely. And I guess like in an ideal world, those are the issues that should be addressed at every clinic visit, really, because you're looking at almost diseases of aging. You're looking at risk factors for morbidity and mortality, which I know that you've written about before, looking at the intellectual disability cohort in Ireland, I think, Prof, in like 2019.
Right.
If you could perhaps comment on key things that should be addressed either by the general practitioner or the adult epileptologist in the clinic setting for these patients with DEE, or really any patient who's aging in the epilepsy clinic.
It's a difficult enough question. I mean, first of all, to go through every system in detail and organize specific investigations and treat the person as a whole, as we should be doing, a complex epilepsy clinic is hugely challenging because realistically, we don't have enough time. So I think a lot of this needs to be done in conjunction with the general practitioner or other specialists, and that has its own challenges in terms of communication. But, clearly things like basic brain wellness that we all should be cognizant of, like making sure the blood pressure is normal, making sure lipids are acceptable, looking at things around body weight. And of course, we have challenges there in terms of some of the drugs we use that can contribute to somebody, let's say, for example, having a less than ideal BMI in terms of using valproate, or sometimes patients on valproate antipsychotic agents, and that can sometimes be an issue. So weight and nutrition and gastrointestinal issues are big comorbidities. They're not easy to manage sometimes. Cardiovascular health, of course. Thankfully, I think most of our patients with DEs don't smoke, so that's good. I'm surprised that in 2025, I know maybe it's not such an issue in individuals with DEs because they don't really have focal epilepsy, although they may have a mixed focal and generalized pattern, that Australian epileptologists still use carbamazepine or still initiate carbamazepine, which is a strong enzyme inducer, which is associated with higher levels of cholesterol, which is associated with clear risk for osteopenia and osteoporosis. And we know that as these individuals get older, they're at risk for falling. So, we need to think about the anti-seizure medications we're using and to try and prevent the chronic ill effects of some of the anti-seizure medicines we're using, because that has a direct consequence as to how well or otherwise an individual with a DE or other epilepsy syndrome will age. So everything, I suppose, as the Buddhists say, everything is interconnected.
Yeah, I really liked that summary, and I like a bit of controversy. Mazepine, again, back to transition, you talked about reviewing the diagnosis, but sometimes
100%.
medications as well.
100%.
And you have to be a little bit brave and
Yes.
think about perhaps trialing something different. How would you feel, Kris, if your son was on a medication for a very long period of time and then you're transitioning and a new epileptologist comes along and points out these comorbidities or potential for comorbid side effects?
Yeah, it's a really good question, because Will's been stable on his current medications for quite a while, like for many years. And we have been, every year we actually visit with our neurologist whether we could take off one. And the conclusion we come to every year to this point is we're stable, we're not going to play with it. And in our situation, we're fortunate that Will doesn't have a lot of what we would consider side effects. So for us personally, I think we would stay with the status quo.
That sounds completely reasonable. I mean,
Yeah.
if he's so well and stable and seizure-free without obvious side effects, and again, I don't know the exact medication, that's perfectly reasonable, of course.
I think parents in general, and I don't speak on their behalf, but would have a sense of nervousness around changing medications. But I think that's also at any age. And, we touched briefly on clinical trials, and there are a couple of clinical trials for new anti-seizure medications coming through the pipeline at the minute. And I would say that there is a lot of interest from parents, not necessarily in that transition, in trialing something new, particularly if their child is still unstable.
Yeah, I mean, I agree with all that. I'm not advocating changing medication. It needs to be considered. It's individualized. It's much easier to make a joint decision to change medications when somebody is not seizure-free, if there's some potential concern around side effects or future side effects. But when somebody is seizure-free and has got there via a very long road, then it's a completely different issue.
Oh, absolutely. I guess I was sort of more asking Kris from the perspective that often our patients aren't seizure-free, and it can be very confronting for the patient, the carers, and also for the epileptologist. It's 2025 and we have lots of different medications that possibly haven't been trialed, including research studies. So I think it's important that we always bring that up in the clinic setting as well.
I think it's important that if resources allow, that complex epilepsy centres are involved in clinical research, and because you're trying to treat a very challenging situation and a group of individuals with very high complex needs, it is an ideal opportunity often to do some worthwhile clinical translational research.
Could I add a question on that? Just thinking, we were talking about some of the novel therapies that might be coming through. How do you see older people, like, for example, my son or older, that have been diagnosed with a genetic condition?
I think potentially, Kris, yes, I think there is value in thinking about not just recruiting children, but potentially involving adults as well. I mean, I certainly have, and I'm sure lots of people have, experience in getting a genetic test in an adult, finally after many years changing their treatment, and that individual significantly doing much better. So if there's no good, what we might call precision treatment for an individual, and they're on a number of traditional anti-seizure medicines and they're not doing well, I think certainly those adult patients should also be considered for potential clinical trials.
So we're getting a little bit close to the end of our time together. I just want to take the opportunity to pick both of your brains, and we might start off with Prof first. What should we be doing in an ideal world to make things better for our patients with genetic epilepsy as clinicians, including advocating for research, etc.?
Again, you left the easiest question to last, Jacqui. We should be advocating with our managers and our administrators. We should be educating our colleagues, and we should be research enabled at complex epilepsy centres and thinking about doing clinical research. And also, what I said earlier, we should be keeping, even if it's local registers of our patients with DEEs in terms of their genetic etiology, and then collaborating among registers, either nationally or ideally internationally. But there's plenty to be done, that's for sure.
And Kris, did you want to add to that from a patient advocacy perspective?
There's a role for us to increase awareness with decision makers and the holders of funds, because I feel like this area is really under-resourced. Neurology and epilepsy in particular is under-resourced compared to other conditions that have complexities to it. So I think we have a role in raising the profile and the need of families so that we can support all the things that Professor spoke about, because often families are listened to when we have that personal story. So I think there's a real role for us there.
Is there anything else that the two of you would like to add before we wrap up today?
Just to add to what Kris said, there's a lot more in terms of funding. Rightfully, oncology and cancer services has got a lot of funding, at least in Ireland, over the last good while. But there's more awareness now in general of brain wellness and brain health, even within the so-called normal population, in terms of how to age and how to reduce our chances of developing age-related dementia, for example. But that all ties into how we practice neurology as well.
I'd suggest to families to link in with organisations like Genetic Epilepsy Team Australia, and we will put the links to that in the show notes of this conversation.
Thank you very much to the two of you. You've both certainly given me a lot to think about things that we could be doing better